Welcome to our sonography lecture on abdomen pathology, part 3 of 4, where we will take a look at peritoneum pathology for the sonographer. This lecture will include topics such as ascites, empyedemas, abscesses, and other collections. We're going to start our lecture off with ascites. So the definition of ascites is that it's the accumulation of serous fluid in the peritoneal cavity. Now, it's important to point out that when you have ascites in a patient, there is going to be kind of an abundant amount of fluid within the peritoneum. If you've scanned GYN studies, sometimes you'll see a little bit of free fluid down in the cul-de-sac. That's not really considered ascites. Ascites is typically going to really fill up a quadrant, be rather obvious in a pooled area within the peritoneum. So oftentimes radiologists won't call ascites until there's a sizable amount of it. Up until then, we quite often just call it free fluid or free peritoneal fluid. That is going to be fluid, maybe a sliver of it in between the liver and the kidney in Morrison's pouch. Maybe you'll see a little bit in that subdiaphragmatic area, just superior to the liver dome. Like I said, maybe free fluid down in the cul-de-sacs. So ascites typically has to have a rather sizable amount and something that's not just physiologically there, like we see with like a ruptured ovarian cyst or something like that. When a patient has a sizable amount of ascites, what typically will happen is that their abdomen is going to start to become enlarged or distended. And sometimes they're going to say, I've been eating well and my stomach just keeps getting bigger and bigger. My pants don't fit as well. My belts are getting really tight. They're going to notice a change in their abdominal girth. Sometimes this change can actually be pretty painful depending on the amount of fluid that they have built up. Along with this then comes some nausea and vomiting. When you have that extra fluid in the peritoneum, it causes pressure within inside. Putting pressure on that stomach can cause that nausea and vomiting. Again, also that fluid building up can make it difficult for the lungs to fully expand, for that diaphragm to drop down into the abdomen. So we quite often see these patients have trouble breathing or even pain with breathing, causing that dyspnea. Lastly then, we know that the abdominal pressure kind of allows for fluids and venous return from the legs to happen more easily. When you have that extra pressure again in the abdomen, it's going to cause some of that fluid to kind of just get stuck in the legs. And so we're going to see these patients have peripheral edema or swelling of their legs. Now, I recently had a patient that literally hit every single one of these. Both the patient and her daughter were saying, just this kind of came on all of a sudden over summer. She was getting treated for lymphedema because they noticed that her legs were swollen. She was having an obvious labored breathing, very hard breathing while she was in the room with me. And I put the probe down, and actually I should back up. As she lays down, she looks very rotund. Not a huge woman by any means, but her abdomen was very distended. And I even knew before I put the probe down exactly what I was going to see. And sure enough, her whole abdomen was just full of ascites. Now, when we see the ascites in the abdomen, we want to take a look at what that ascites looks like. When it is very clear and anechoic, that usually lines up with transudate ascites. So with transudate ascites, we see this most commonly as, if we were to bring a sample of this down to the lab, we would see it as a very thin yellow fluid. It's typically going to have a very low protein count and low specific gravity, meaning it has a lot of water within it. The exudate acidic fluid then is going to be more high protein count and high specific gravity, meaning that it has more particles within it, or more pus, or more bacterial pieces within it. So transitive ascites is often seen with cirrhosis. So remember, that is a disease of the liver. Alcoholic hepatitis, so inflammation of the liver caused by drinking alcohol. Hyperproteinemia. So hypo means below, proteinemia is low protein in the blood. That protein typically is going to be albumin. So remember, albumin was that kind of sponge that floated around in our vessels and would take all that intercellular fluid and get it to the liver, get it to the lymph nodes, and get it processed the way it needs to. Well, when you're low on your albumin, that intercellular fluid doesn't have a transport anymore, and so it just kind of leaks into the peritoneum cavity. So hypoproteinemia or low albumin levels will result in ascites developing. Portal vein thrombosis, peritoneal dialysis, and malignancy are also going to cause transitive ascites. Remember, that's that clear, thin fluid in the peritoneum. Some causes then of the exudative ascites you're going to see are going to be more related to inflammation processes like pancreatitis or an abscess. Peritonitis, again, is the lining of the peritoneum gets infected. That causes peritonitis. Ischemic bowel is bowel that's no longer getting blood flow. Bowel obstruction is bowel that is no longer passing content through it. So I think a good way to remember this is that the non-infectious or none of the itises have that thin fluid, where the itises are going to have more of a thicker fluid. You can kind of think of it as like pussy fluid within the peritoneum. When ascites has been visualized in the abdomen, it's a good idea to make sure that you're taking pictures of every quadrant showing the extent of the fluid within the peritoneum. Because it is free fluid within the body, it does pool to the most dependent area. So if you have your patient slightly sitting up, then that fluid is going to flow more down into the pelvis. If they are flat on their back, you're most likely going to get an even distribution of the fluid. If you roll them to one of their sides, then the fluid's going to float that way. So your best bet is to have them in the supine position as flat as possible so you can evaluate how that fluid is dispersed into the 4 quadrants and take pictures of them. Treatment for ascites then can include more diet-based, so stop drinking alcohol, slow down on your sodium intake, maybe take some medications like diuretics. Diuretics help you pee off fluid a little bit more, makes your kidneys a little bit more active. Or we can do some more interventional techniques that we talked about with some of the liver diseases that typically cause ascites, such as a TIPS procedure or a paracentesis. Remember, the paracentesis is where a needle or a catheter is inserted into the peritoneum, and that is going to then be attached to a bottle that will kind of vacuum out the fluid within the peritoneum. On ultrasound then, we will see pockets of fluid within the abdominal cavity. We need to be conscious of very small pockets. Sometimes those are going to be right next to the diaphragm, sometimes in Morrison's pouch. Sometimes you'll see it right on the left lobe, kind of in between the stomach and the left lobe, are common places that a little bit of fluid likes to hang out. Otherwise, when it's just a massive amount of fluid within there, you're going to see a large amount of anechoic fluid, typically then with bowel floating within it. We then want to also assess the echogenic appearance of that fluid. Is it completely anechoic, or does it look like there are particles floating in it? Does it look like it has more of a hemorrhagic view to it? Maybe there's more clotted blood within it. So we want to make sure that we are looking all throughout the fluid for any sort of internal complex echoes. So here's an example of simple ascites in a patient. We've got anechoic fluid posterior and inferior to the liver. We also have some superior to the liver as well. It's important to identify where the diaphragm is, and it's here in that picture. So because we have fluid inferior to the diaphragm, we can comfortably call this ascites. Remember, any fluid that is superior to the diaphragm is called a pleural effusion. In fact, this patient might have a little bit here, or that might possibly be some mirror artifact. So it's important to identify where the diaphragm is so you can determine, is it in the abdominal cavity or is it in the thoracic cavity. Here's an example of a very large amount of free fluid. So we can see bowel loops floating in the free fluid. However, this is no longer that simple free fluid or simple ascites, transitive ascites. This has particles within it. So this would be considered exudate ascites. Now this could be related to an infection in the body, or it could be related to a hemorrhage in the body. And here's another example of exudative ascites. This time we are seeing loculations through the ascites. This quite often represents adhesions where the body has been trying to wall off infections, and we end up seeing kind of these loculated pieces floating in the ascites. If this patient were to have a paracentesis, the needle would actually need to pierce through these loculations if they are completely closed off to get the fluid out of them. So we want to make sure that we are visualizing that needle and where it's going when we drain these patients. Next up then, we're going to talk about empyemas and abscesses. So when I was doing some research for this lecture, I came across the word empyema, and it actually kind of fits more what we were talking about when there are abscesses that form outside of organs. So empyemas, by definition, are typically going to be collections of pus in areas that are already a cavity. So the uterus is a cavity. You can get an empyema in your uterus. You can get one in the gallbladder. You can get one in the peritoneum. Most commonly, you're going to get empyemas up in the thoracic cavity, in the pleural space. And so empyemas sometimes are only referred to as lung abscesses that happen up there. However, their general definition term does refer to anytime there is pus collected within a space. So for that matter, we're going to kind of use empyema and abscess interchangeably. Abscess is typically more defined as a collection of pus within parenchyma, so like a liver abscess, a kidney abscess, spleen abscess. It's going to be something within parenchyma. So empyemas are more the correct term for abscesses that form in the peritoneum, but I think more often than not you're going to hear them referred to as abscesses versus empyemas, because empyemas are typically reserved for abscesses in the thoracic cavity. So I hope that wasn't overly confusing. Basically, all you need to know is that empyemas/abscesses are caused by bacterial infections. So these infections get out of the area that they infected. They start traveling around the body. The body's like, whoa, we don't want that. Wall that off. Get rid of that. And so the body makes these thick walls around these bacterial infections. Bacteria gets kind of cornered and starts creating pus and all this gross stuff. And that's where our abscess comes from. And so what we basically need to look for is anywhere there can be fluid within the peritoneum, an abscess can form. So we want to make sure that we're looking in that subdiaphragmatic space. We want to make sure that we're looking all the way through all the quadrants, looking for any phlegmonous changes. We're going to see echogenic fat, kind of these stranding layers of phlegmon through there, or we're going to see these walled off kind of circular structures with thick walls and debris within. Typically when a patient has an abscess, it's because they've had an infection. So it's not uncommon for them to have a fever along with this, and typically some sort of tenderness or swelling in the area that the abscess is located. More often than not, they probably have had surgery, and that is probably your best location to start looking for an abscess, because that would be the best opportunity for bacteria to be introduced into the peritoneum. Treatment for an abscess then is typically going to require very strong IV antibiotics, an admission to the hospital, and possibly a drain placement to allow that bacteria, to allow that pus to flow out of the body. So on ultrasound, we're actually going to see really varying appearances of these abscesses. It can really depend based on the time that it's been in forming in the peritoneum. It can depend on the amount of space that it has to form. So if you have an abscess up in the subdiaphragmatic area, there's not a ton of space in between the diaphragm and the liver. So those might be kind of smaller compared to one that might form in the right lower quadrant. It can just push that bowel out of the way and can become this giant abscess. When you see the abscess, they typically are going to be fluid filled with these kind of thick, irregular borders, but you also might see some stuff inside of it. So we consider these typically complex masses. That complexity might be some debris floating within it. It might have a fluid level. The bacteria might be producing gas, so there might be some echogenic foci within it that are causing that ring down artifact. And because the peritoneum really does cover most of our abdominal cavity, abscesses are not uncommon, more towards the pelvis in the bowel area. So we want to make sure if we think that we spot an abscess in the bowel, that we actually really do evaluate the surrounding bowel, make sure that it's not attached to the abscess, make sure that it is free to peristalse, and that we can visualize separation of the bowel from the abscess. So here's an example of an abscess. This one is up in the thorax. So this is a true empyema, but we can see all these loculations. We can see debris within the loculated fluid areas. So this is definitely an abscess, an infection in the thorax, a true empyema. Here is a loculated area down in the pelvis. We have the urinary bladder here, and then we've got this loculated, kind of gross looking irregular walls, complex mass in the area. We also have some bowel in the area as well, so we would want to make sure that this is peristalsing, not adhering to this mass. Here is an example of a subphrenic or subdiaphragmatic abscess. So the L represents the liver. So this is all liver tissue. And then we have the diaphragm. Up here we have the pleural space, which actually has some fluid in it. So they're calling it a pleural effusion with that PE. But the main focus of this picture is the fluid collection, the C here. This is, again, a loculated complex mass that is sandwiched in between the diaphragm and the liver. So again, anywhere that fluid can collect in the peritoneum, in the cul-de-sac, in the anterior cul-de-sac, in the subphrenic spaces, in Morrison's pouch, in the gutters, anywhere that fluid can collect, an abscess can form. Lastly, we do have some other collections that can form within the peritoneum that have special names for them. A biloma or biloma is a collection of bile in the peritoneum. Often what will happen is the patient will undergo a cholecystectomy. They might not section off all of the bile ducts, and so that bile just kind of keeps going and leaking into the peritoneum. Well, the body doesn't want that, so it kind of walls it off, and what you end up getting is a cystic-like area filled with bile. So if a patient is coming in post-cholecystectomy and you looks like you almost kind of see the gallbladder still there, more often than not, it's going to be a biloma. They can also occur if the gallbladder ruptures. So we talked about emphysematous cholecystitis and we talked about gangrenous cholecystitis, both conditions that can lead to rupture of the gallbladder. If that occurs and the bile spills out into the peritoneum, that again might cause a biloma to occur. If these bilomas are left to sit long enough, especially in the setting of gangrenous or emphysematous cholecystitis, there's a really good chance they're going to turn into abscesses. Another collection that we might see in the peritoneum is something called a urinoma. Urinomas are going to typically follow up some sort of surgery or injury to the kidneys. So say they had surgery to remove part of the kidney, so they had a partial nephrectomy, and the tubules of the kidney keep leaking urine out into the peritoneum versus putting it into the pelvis of the kidney. There's going to be urine within the peritoneum. Again, the body doesn't want that, so it's going to wall it off, and we're going to get the cystic structure that is filled with urine. So if a patient, again, comes in post-surgery, post-injury to the flanks or surgery to the kidneys, and we see kind of the cystic structure in the area, we should consider urinoma as a differential. Lastly, cysts can occur anywhere within the body. The peritoneum is not immune to cystic formation, and they can be simple cysts, thin walls, anechoic through transmission, or we might see some hemorrhagic cysts also occur, which are going to have more of a complex appearance to them. So here's an example of a biloma. Again, a patient most likely has already had their gallbladder removed. You put the probe down and there's this what kind of looks like another gallbladder sitting there, and you're totally going to think that you have lost your mind, and you're going to ask the patient, are you sure you had your gallbladder removed? And they're going to go, yep, but it's going to be painful. It's not going to feel good. This is most likely a biloma. Here's an example of a urinoma. We can see a collection of urine outside of the kidney. We can actually even connect it back into the sinus. So this helps us to prove that this is a urinoma versus a perinephric fluid collection versus a hematoma near the kidney. And that brings us to the end of part 3. Next up, we're going to talk about a few diseases that affect the abdominal wall.